Hello, my name is Michael Schulder. I'm the Vice Chair of Neurosurgery at Northwell Health and at the Zucker School of Medicine at Hofstra Northwell. And of relevance to this discussion is that I'm the Director of the Brain Tumor Center at the Northwell Neuroscience Institute. So I'd like to answer some questions about brain tumors that you might have and provide general information about brain tumors. And the overall message I'd like to give is that for many people with many different kinds of brain tumors nowadays, there are successful treatments and people could be cured and live for many years in good condition after such a diagnosis. So the symptoms or signs, the things that are seen on neurological examination from a brain tumor, depend primarily on the size and the location of the mass. And if you look at this image, at this pie chart, one way of classifying brain tumors is indeed their location. So what you see here is that the plurality in the light green color, the largest single group of tumors that occur that we consider brain tumors are actually not in the brain, they are inside the head, but potentially affecting the brain, and they're from what's called the meninges. That is the lining inside the skull that also surrounds the brain. Another significant number of tumors are at the base of the skull, and those are also not strictly speaking in the brain, although they can affect the brain and related nerves in profound ways. Maybe a more familiar way of classifying brain tumors is talking about their origin. Are they primary or metastatic? In other words, do they arise within the brain or within the head itself, or do they spread from somewhere else? And related, what's their histology, meaning what does the biopsy show? What do the cells of the biopsy look like under the microscope? And from this, we derive the overall concept of a tumor being benign, meaning it may cause problems and symptoms by growing where it is, but it can be cured with surgery or perhaps just observed, or malignant, meaning it is some form of cancer and therefore requires a more aggressive kind of treatment. So if you look at this pie chart, you'll see that the majority of the tumors are, practically speaking, actually benign. If you add the meningiomas in the light green with the tumors of the pituitary, just with those alone, you are coming in at a little over 50%. And the great majority of tumors that fall into those categories are benign. And there are some other tumor types mixed in the rest of the categories listed on this chart that are benign as well. Now, of course, that's not true of all brain tumors, and I'll talk about the malignant tumors as well. So to talk about primary brain tumors, they're not rare, and odds are quite high that you know someone, perhaps in your family, extended family, friends, who's had such a tumor. But the majority of the primary tumors, the ones that arise only within the head each year in the US, are actually benign, and only 1/3 are malignant. Now, of course, for those 20,000 or so people, that's a very severe problem with which they have to deal, but it is by far not the majority of patients with primary brain tumors. On the other hand, by far, the great majority of brain tumors are not primary, they are metastatic. They are malignant tumors that are spread from somewhere else in the body because of cancer somewhere else in the body. And the most common types of tumors that spread from the body to the brain are lung. By far, the great number of those are lung, followed by patients who have breast cancer, renal or kidney cancer, and melanoma. And other cancers can do as well, but those are by far the major 4 categories that spread to the brain. Now, what kind of symptoms do brain tumors cause? Since in general, the symptoms are related to the size and the location of the mass, the symptoms are in some sense generic It could be a primary tumor, it could be a metastatic tumor, benign or malignant, but the symptoms may be similar. So one category of symptoms are related to what's called increased intracranial pressure. Just like you have blood pressure that might be increased, pressure in your head or your intracranial pressure can be increased. And when that pressure passes a certain point, you might complain of headache. If it gets worse, the pressure may cause you to feel nauseated and to throw up. And when it gets even more severe, you may be lethargic, you may be not fully awake or difficult to awaken. Another category of symptoms are what would be called focal symptoms or focal complaints. They're related specifically to the location in the brain or inside the head of a tumor. So if you have a mass that is affecting the area that controls movement, you'll be weak on the other side of your body. If it's affecting the nerves that relate to vision, the optic nerves, or the part of the brain in the back of the head called the occipital cortex, where you see, you'll have some visual loss. And as the slide says, if it's in an area related to language function, you might have trouble speaking or understanding language. And the last major category of symptom is you could have a seizure. When cells in the brain have abnormal electrical activity, you might have abnormal movements of the brain and you might pass out, and those are different forms of seizure, and that is relatively often the presenting symptom, the way that someone finds out that they have a brain tumor. In 2021, there's no question that the way to diagnose someone having a brain tumor is to do contemporary methods of imaging. In most people, that means doing an MRI, which is completely safe, or a CT scan if for some reason they can't get the MRI. It may take too long, you might be claustrophobic, you might have a pacemaker that doesn't allow an MRI to be done. And in those cases, those scans will show if there's any kind of significant mass. And a CT uses X-rays, but for the purposes that we're talking about here, it is safe. As long as you don't get a CT scan every day in your life, you have nothing to worry about from it. And as I mentioned, an MRI is completely safe. Now, once you've had an image that shows a brain tumor, in most cases you will need to either have it removed or you will need to have a smaller surgery called a biopsy to find out what it is. Now, some people have tumors that we can diagnose based on the image alone. If you look on the upper right, you'll see an MRI of somebody who has what's called a vestibular schwannoma. An older fashioned term for that kind of tumor is an acoustic neuroma. And these are benign tumors that arise from nerves that come out of the brain and relate to hearing and balance and facial movement. I'll discuss it again some more later on. And this scan is diagnostic, or the medical term, fancier term, is pathognomonic. We could tell that this is a vestibular schwannoma, and we could do certain non-invasive treatments that I'll talk about later based only on the scan. On the bottom right, you'll see an MRI of somebody with a pituitary tumor. And this is what's called a pituitary macroadenoma. It's a large tumor. Now, you see the text refers to microadenomas, and those tumors can be diagnosed as well with MRI and other tests. And as you'd expect, the difference between micro and macro is small and macro is big. So treatments can be based on the MRI appearance of these tumors without a biopsy. So broadly speaking, what kind of treatments are available for someone who is diagnosed with a brain tumor? If the tumor arises within the head and or within the brain, then the treatment is ideally curative with whatever method is going to be used. Whereas if the treatment is for a metastatic tumor, i.e. is for a tumor that has spread from a cancer elsewhere in the body, the treatment is mainly palliative, meaning it will be aimed at relieving symptoms, which doesn't mean that you can't live for many years afterwards, but it is not aimed at a cure. That will depend on how the treatments for your overall cancer will go. But the good news is those treatments have improved a whole lot in the last few years, and I'll discuss that as well. Now, even today, with many advanced treatments of focused radiation techniques, new chemotherapies, targeted therapies, immune therapies, the best cure for a tumor remains to completely remove it. The problem is, if you have a brain tumor, you don't have the latitude or the ability to do what is possible for someone with a colon tumor, let's say, or a lung tumor, which is that you could take some of the normal tissue around outside the tumor along with the tumor. So if you want to make sure that all the colon cancer is removed, and let's say it's 2 inches big, 2 inches in diameter, well, you can go another 2 inches on each side. And if you're still not sure, you can go even 2 inches beyond that. And you got a 6-foot colon. Those extra inches are not going to matter. You're going to have normal digestion. In your lung, you could take part of the normal-looking lung around the cancer to cure somebody with surgery. But because of the need to preserve your brain and your mind and your function, that option does not exist when one is doing surgery or having surgery for a brain tumor because of that need to preserve brain function. So forgive me, I'm a historian, especially of neurosurgery, so I think it's relevant and useful to talk about some of the surgery of brain tumors and how it's evolved over human history. So until about 160 years ago, the only surgery that could be done on one's brain or one's skull was for things that were visible on the outside. If you had a head injury, maybe if you had an infection that broke through the skull and the scalp over it. And that was really it. And it was the discovery of the neurological examination, things that you've heard about, that the right side of the brain, let's say, controls movement on the left side, that we speak, most people, and certainly most right-handed people, we speak related to certain areas on the left side of the brain. Our vision's controlled in the back of the brain. So that allowed surgery to be done without anything visible on the outside. So in fact, the first craniotomy, meaning surgery done to temporarily open the skull, to find a brain tumor, and then to close the skull, of course, was done in 1884 based on the examination of somebody who had weakness on the left side of their body. Then a real revolution happened in the first decade of the 20th century. A surgeon named Harvey Cushing wanted to change the world of brain surgery, which until then was done very rarely, and it was very dangerous. So he coined the term neurological surgery, which we now shorten to neurosurgery, and he said this is a separate field. If you're going to do it, you got to focus on this. You can't be doing general surgery or orthopedics or OBGYN. You have to focus on surgery of the brain. And he lowered the death rate or the mortality of brain surgery from well over 50%, like a bad coin toss, to well under 10%. And this was in the beginning decades of the last century. So a major advance in human history and certainly in medicine. And these are photos taken from Harvey Cushing's 2000th brain tumor operation in 1929. And some things about his operating room look antique. That's Dr. Cushing in the middle of the photo on the left. You have people in the gallery in street clothes, although they are wearing masks. But otherwise, around the table, people are wearing masks and they're gowned and gloved. It doesn't look that different. And the instrument tray on the right includes many tools that we still use nowadays. And in fact, we use forceps and other devices still named after Harvey Cushing from a century ago. So I'd like to talk now about different kinds of primary brain tumors. And the most common tumor that arises within the brain itself, not within the head, but within the brain itself, is called a glioma. And there are different kinds of gliomas. But what they have in common is that they arise from the glia, and these represent over 90% of the cells in your brain. So the glia are not the cells with which we think and that control, let's say, movement and speech and vision. Those are the neurons. The glia support those cells. They help with the physiology and moving chemicals in and out. The neurons would not work without the glia around them. And the gliomas arise from those cells called the glia. And there are two main types of these tumors. There are other categories, but we don't have to get into those now. So oligodendrogliomas are from a certain kind of glial cell, and these tumors often can be treated successfully with chemotherapy, and between surgery and chemotherapy can be effectively cured. If you look on the right, on the upper right, this is the image from 25 years ago of somebody I operated on with an oligodendroglioma. Afterwards, he was treated with a particular regimen or combination of chemotherapy, which already then was known to be effective for these tumors. And on the lower right is his scan from many years later, and I'm still in touch with him. I still follow him, and he has no evidence of the tumor growing back, and this is after 25 years. So he is, in essence, cured of that tumor. The other and somewhat more common type of glial tumor is called an astrocytoma, and that is a tumor that arises from a different kind of glial cell. And these tend to be more aggressive than oligodendrogliomas, with fewer effective treatments. And the most aggressive of these tumors are known as glioblastomas. And they do have a worse prognosis. In fact, generally speaking, a pretty bad prognosis. Certain famous people have died of them in relatively recent years. Two senators, Ted Kennedy, died about 10 years ago, and John McCain died about 2 years ago from a glioblastoma. Now, just to give you a sense of what the surgery can be like for these tumors, this is a head-on view MRI of somebody who had an oligodendroglioma, and that's that white thing you see on the right side of the image. These images were taken with an MRI in the operating room with what's called an intraoperative MRI. And this young man's symptoms were only a seizure. As I mentioned earlier, that's one of the main categories of symptoms of someone who has a brain tumor. So on the upper left, you see a box that is called a brain stimulator, and that generates a current that we can apply to the brain, as you see on the upper right. And that's a way to ascertain 100% where what's called the motor cortex is. That's the area of the brain that controls movement. By doing so, we confirm that the tumor is actually in front of that area, so I could take out the whole thing without giving this person weakness on the right side. The lower left shows how that removal or that dissection of the tumor is begun using a suction device. That's the rod that you see, and the thing with two prongs, that's a bipolar cautery, and that applies small currents of brain to currents of electricity that cause heat, and it controls bleeding, and also in a very controlled way cuts through the tumor at its margin, because we want to leave all the normal brain around that. The image on the left is taken from the intraoperative MRI unit. On the leftmost column, you see the image before the surgery. In the middle, there are parts of the MRI that were taken after I thought the tumor was completely removed, but the pink circle is placed over a little white streak that shows an area of tumor left behind. So I took that out, and the upper right shows how I used a tool to find exactly where that abnormality is, because you can't see it with the naked eye or even with an operating microscope. The lower right shows how we're working through the magnet to take that tumor out. And if you go back to the MRI images on the right side of the column, that's the last image that shows that the tumor is in fact completely gone. With a glioblastoma, it's a different story. Even with modern mapping techniques that we have, we could do what's called a functional MRI and see on the image where you move, where you speak, for instance. We could take the tumors out safely, but surgery alone is not a cure if you have a glioblastoma. You need other kinds of treatment, and the standard treatment involves radiation therapy for 6 weeks, 5 days a week, and also 6 months of chemotherapy pills taken every day during the radiation therapy and 5 days a month for 6 months after that. That's called the standard of care. Because glioblastomas usually grow back after that treatment, academic centers and in some cases community hospitals do offer what are called clinical trials to try to find better treatments for people with these tumors. Now, a clinical trial is in essence an experiment to try to find a better treatment. And the reason why that's done is because the standard of care, although it can be very effective in some people, tends to have a measurable but limited benefit. So we're looking for ways to make those treatments better. And these clinical trials might include a new kind of chemotherapy. They might be based on a vaccine, or they might involve using viruses to bring treatment into the tumors. So this is actually a random screenshot I took off of our panel of clinical trials that we either have open now at North Shore University Hospital and in the Brain Tumor Center, or have had open. And these include, if you look on the top, vaccine trials, and in the middle, an immunotherapy trial, and at the bottom, a trial that involved injecting a special modified virus directly into the tumor. So having said all that, it is still true a patient can live for many years after treatment for a glioblastoma. So it is not automatically something that a person has to die of. This, to some extent, relies on somebody having a favorable tumor biology in ways that we don't yet fully understand, but that's also another reason why people deserve appropriately aggressive treatment if they have a glioblastoma diagnosed. So here's a case example of one such person. If you look on the top scan, you'll see that in April 2013, this person was diagnosed with a glioblastoma in the part of the brain called the right temporal lobe, just above and a little bit in front of the right ear. So she had surgery, the tumor was removed, she had radiation therapy and chemotherapy, and she was neurologically intact and feeling okay. And nothing happened for 3 years. That's a pretty long time for many people with a glioblastoma. But if you see the arrow under April 26, 2017, that white streak is an indication of tumor growing back. So she was treated at that time with a supplemental dose of radiation called stereotactic radiosurgery. And you'll hear more about that in a little while. And she responded well to that. 2 years later, there's no sign of any tumor. We're looking for white things that show up on the MRI. But a year ago, she had some more evidence of tumor growth further forward. If you look on the lower left, she got another dose of stereotactic radiosurgery. And now a year later, you see some of the side effects of that radiosurgery, the focused radiation treatment, but no evidence of active tumor. And this lady is neurologically intact 8 years out from her diagnosis. Now I'd like to switch gears a little bit and talk about another kind of primary tumor, but this is not a tumor that arises in the brain. It arises inside the head, and it causes symptoms by pressing on the brain, and that's a meningioma. These tumors are almost always benign, and they arise from what's called the dura mater, Latin for tough substance, and that is the lining outside the brain and inside the skull. These tumors are also classified by their grade. A grade 1 meningioma is completely benign and is, in most cases, cured if you take the whole thing out. And if you take that lining of the dura out along with it, the thing from which the tumor arises. Now, a grade 2 meningioma is still benign, but we know from many years of observation that it's a somewhat greater propensity for regrowing even after treatment. And that's why there's still a debate going on around the world whether we routinely have to apply radiation therapy for people with grade 2 meningiomas. And most of the time when the whole tumor is removed, the answer is no. And we follow people and see if over time they're going to need any kind of radiation treatment. And much of the time, the fact is that they don't. The right side shows a case example of somebody with a tumor. It was a woman in her mid-40s who complained of headache and started to have some tingling on the left side of her body. The scan is a head-on scan, so the right side of her brain is on the left side of the image. And this is what the tumor looks like at the time of surgery in the middle view. That's obviously a surgical view, and we've opened up the lining of the brain, the dura mater, and the tan thing is the meningioma. It's attached to the dura mater, and we're beginning to just peel it back, elevate it off of the brain, which you see around that. And that's what the tumor looks like, taken out in one piece with its so-called dural attachment attached. Now, sometimes meningiomas can result from prior radiation therapy for a different kind of tumor. Now, almost by definition, if your meningioma is induced by radiation, it will be grade 2, but it could still be removed safely without the need for any other treatment. So this MRI belonged to a 54-year-old woman. When she was a teenager, she had a primary brain tumor. And she had that removed, actually with 2 surgeries, and had radiation therapy for that. So as a result of that surgery, she cannot see off to the left side of the world because it affected her visual center on the right side of her brain. But now, when I saw her for the first time, she was going blind because the vision on the left side of her brain was being affected by this meningioma. So this is a very difficult circumstance. How do you take this out? Because she needs this tumor treated, and treating her with radiation only is not going to work, and there's no good chemotherapy. So she needs surgery. How do you do it without making her completely blind? I showed this woman's scan to some very well-known brain tumor experts from around the country. Do you go through the brain? Well, of course not, because that will surely blind her. And you can look at that cartoon that shows up on your screen now. Do you come from the right side, where the first surgery was 40 years ago? Well, you can't really do that because there's still some functioning brain on the left side. Do you lift up the left side of the brain right under the tumor and go out? Well, there's a real risk of affecting her visual brain there and making her totally blind. So the answer really turned out to be to go further underneath, to go over the part of her brain called a cerebellum and kind of approach the tumor from underneath. And that's what these surgical images show. And I won't belabor the point. From the upper left, you could see the lining underneath the tumor exposed. Then it's being cut on the upper right. And on the lower left, the tumor is beginning to deliver itself from away from her brain, and then it's completely removed. And this woman, 5 years later, has no visual loss on the left side. She's back to her baseline vision, and the tumor has not grown back. So that's all I'll say about primary brain tumors, of the main categories of tumors. But metastatic tumors are by far the most common type of tumors. Almost 10 times as many people have a metastatic tumor per year in the US. So this is a public health level issue. This is not a rare problem by any means. And about 1/3 of people who develop cancer do get a tumor that spreads to the brain. And because treatments for cancer are getting better and people are living longer with their disease, they're more likely to get a tumor that spreads to the brain. So a revolution that has occurred in treating people with metastatic brain tumors over the last 20 years has been the use of stereotactic radiosurgery. And in tandem, the outlook over the last 10 years for these patients has vastly improved because of what are called targeted therapies aimed at specific mutations in their cancers, as well as immune therapies. These are things you probably read about in newspapers, in magazines, general media, online, and it's not hype. it really has made a huge difference for people with cancer. So people who would have had a death sentence from certain kinds of tumors as recently as 10 years ago can be effectively cured nowadays. And the use of stereotactic radiosurgery has played a big role in this. So what is radiosurgery? The stereotactic refers to a computerized method of guiding treatment, in this case, radiation. And this is a schematic illustration on the lower right, or a cartoon that shows how a device called the gamma knife works, where 192 beams of radiation are focused on a single spot. Each beam gives off almost no radiation, but where the beams add up, where they intersect, that's where the radiation is delivered. And this by far is the best and most potent way to treat patients with metastatic tumors nowadays. So this is still often referred to as a new and high-tech kind of treatment, but the fact is this was invented almost 70 years ago by Lars Leksell, who is a brilliant, pioneering Swedish neurosurgeon. And he actually went through different methods of trying to do radiosurgery, a term that he coined, and he came up with a device called the gamma knife, which has been operating now around the world for 53 years. It's gone through multiple generations of technological refinement, but it's hardly something brand new. And he defined, that is, Leksell defined radiosurgery as the closed skull destruction of an intracranial lesion, meaning in essence you were getting rid of something inside the head without having to literally opening the head using radiation. Now, there are other ways of doing radiosurgery. You could do it with a standard linear accelerator, the most common device used for doing radiation therapy. And a particular modification of that is called the CyberKnife, that uses a LINAC or a linear accelerator mounted on a robot. And you might have heard the LINAC programs advertised on the radio. Now, when can you do radiosurgery or SRS, stereotactic radiosurgery, for someone with a metastatic tumor? We want to make that tumor not grow and ideally go away. So it doesn't work if the tumor is too big. And it has to be something less than 4 centimeters, about 1.5 inches in diameter, and ideally even 3 centimeters in diameter, a bit smaller. Now, for the first few decades, when radiosurgery was being done for somebody with a metastatic tumor, it was reserved for somebody with only 1 tumor, and maybe if you were pushing it for up to 4 tumors. What we know nowadays is that for sure it works for people with as many as 10 tumors, and I personally have treated people with the gamma knife, with radiosurgery, with dozens of tumors with equally good results, and have published on that, in fact. And the point is that by doing so, your radiation is going only to the tumor and not to the healthy part of someone's brain. So here's an example of part of someone's MRI. They had many more tumors than you could see, but this is only one image, or one slice, as we call it, of the MRI. And he had multiple tumors from melanoma, and not very small tumors, as you could see. We treated him with a gamma knife, and his scan 2 months later shows that the tumors have either disappeared or dramatically shrunk in size. And that's what a person who's getting radiosurgery for metastatic tumors can expect. This could be used as a primary treatment in many people. This patient was a 59-year-old woman who didn't smoke, but turned out to have lung cancer. Her symptom, though, that she presented with was some weakness and numbness of her right hand. And if you look at her MRI in the upper right, you could see that she's got this relatively small but unfortunately placed tumor, and her workup showed on her chest CT on the lower right that she had a big mass in her left chest. So no question that the best treatment for her brain tumor was to treat her with SRS, with radiosurgery. She got that in a single treatment. The dose was what's called 18 gray. That's a typical measure of radiation delivery. Her lung tumor was then removed, and she got chemotherapy. This is all pre-contemporary cancer treatments. So 10 months after the MRI, you could see it looks worse. She's got a larger lesion. She's got some swelling, although interestingly, she does not have any new symptoms. And what her MRI spectroscopy shows, and that's a way to use the MRI to measure the chemicals in someone's brain, is that this is most likely a reaction to the radiosurgery. So we just watched her, and in fact, that new expanded lesion shrank down. The whole thing is much smaller than it was at the beginning. And 11 years later, she has no recurrence of the tumor in her brain, in her chest, or anywhere else, and she's working as a physician full-time, in essence cured of her lung cancer. It is sometimes desirable to combine surgery and stereotactic radiosurgery because you're not sure of the diagnosis, or the tumor is causing symptoms, or it's too big to treat with radiosurgery only. So here's an example of a woman who had a melanoma removed from her arm in 2010. And she was thought to be cured based on that surgery, but 3 years later, on Christmas Eve, Merry Christmas, she presented with problems with her speech, and she also was found to have tumors in her lung. So this is metastatic cancer to the brain and to the lung. So on Christmas Day of 2013, I took out that brain tumor, and her speech returned to normal. And as planned from before surgery, about a month later, she got SRS to the area where the tumor had been. And then she started a year of immunotherapy, which was a new treatment at the time, with what's called ipilimumab. The brand name of that is Yervoy. 2 months later, she had a new metastatic brain tumor found. If you look at the MRI, you could see that little white area on the upper left image, and that was treated with a separate SRS. But now, 7 years later, after the surgery, SRS, immunotherapy, no evidence of disease anywhere. That scar that you see on the MRI there is just the leftover effect of her treatment. So she is in effect cured of her metastatic melanoma. And a decade ago, I'll tell you, there would have been no good treatment for that. Now, to get back to primary brain tumors that are benign and can be diagnosed based on the image alone, the most common are vestibular schwannomas, also known as acoustic neuromas, as I alluded near the beginning of the talk. That's sort of an old-fashioned term. These are benign tumors that arise from the vestibular nerve. That's a nerve that's responsible for balance and coordination. And it runs really in tandem together with the cochlear nerve. That's the nerve we use to hear with. It brings sound information from the ear into the brain. So common symptoms, in addition to perhaps loss of balance or vertigo from the vestibular nerve, that's a sense of the world spinning around you, common symptoms are hearing loss and tinnitus, which is a ringing in the ear. Now, complete surgical removal of these tumors does result in a cure, but there are high risks of losing hearing in that ear, of having weakness of the face, like from a Bell's palsy, because the nerve that controls face movements is really attached to those other nerves and to the tumors. And depending on the size of the tumor and a person's medical condition, other neurological or medical problems may occur. So we've known for decades that SRS is a safe and effective treatment for patients with vestibular schwannomas. And in fact, close to 100% of the time, a person could be cured with no side effects from these tumors. On the lower right is a plan of somebody who was treated with the Gamma knife using SRS to treat a vestibular schwannoma. The yellow line that surrounds the tumor indicates the radiation dose that is going to be delivered to the tumor. And on top, at the very most top, you see the image of somebody's vestibular schwannoma before treatment. He was treated with SRS, and 5 years later, the tumor has shrunk down somewhat. These tumors rarely disappear after treatment. They typically shrink down somewhat and just stay that way, and you can go on and live 50, 60 years after that with no symptoms. However, sometimes if the tumor is too big, the person may need surgery and then have SRS afterwards as a combined treatment. So this patient was a 52-year-old woman when I met her. She had hearing loss in right ear, but the tumor was so big that she was beginning to lose balance. If you look at the image, you can see the mass is compressing the part of her brain called her brainstem. And that is potentially a dangerous situation. And I advised her at this point that she really needed surgery and she should consider having surgery and then having SRS to the rest of the tumor, or she could have had SRS only at this point, but she didn't want any treatment. So she came in a year later, the tumor had noticeably grown. There was really significant pressure on her brainstem. Her balance was off, she was falling, and I said, boy, you really need to have surgery for this. But I made the point of not planning to try to remove the whole thing, to give a chance, the best chance of preserving her hearing and not giving her facial weakness. So this is a view through an operating microscope. And to orient yourselves, her ear would be above the screen, the top of her head would be to the left, her chin would be to the right, and her left ear would be to the bottom. So what we're looking at there is the tumor itself, much of which has already been removed at that point. And on the upper right, after I've taken a little bit more out of the tumor, and while I'm doing this, I'm making sure that the facial nerve, the hearing nerve, are all still in good working function. I put in a small piece of a ruler to see how much is left and to determine if I've taken out enough. On the lower left, I'm using a probe to test the function of her facial nerve, which is still working just fine. I've taken out a little bit more tumor. And on the lower right, by testing the nerve a little further towards the ear, beginning to lose some of that function, and then I know it's time to stop because I don't want her to get facial weakness. And what the upper left shows is the gamma knife radiosurgery plan for this patient 6 months after the surgery. As you can see, there's a small remnant of the tumor that's still left behind. And on the lower right, 7.5 years later, there is that leftover tumor, a really very small fraction of the original tumor. She still has her hearing, her facial function is normal, and her balance has returned to normal. As I alluded to at the beginning of the talk, the other kind of primary brain tumor that we can diagnose based on the imaging alone are various kinds of pituitary tumors. Now, these tumors are unique in that they can cause symptoms not related to their size and the location, but the substance that they secrete. And those substances are hormones. You have hormones that are made in different parts of your body, but the pituitary makes several of them, and some of them are critical for life, and others are important for other functions in life. So sometimes these tumors present when they're very small, and those are called microadenomas. Micro meaning small, and the adenoma is just a general description of the tumor type. So the most common of those kinds of tumors is called a prolactinoma. And if the tumor makes a hormone called prolactin, then a young woman will stop menstruating, will not be able to conceive, and women of any age may get a discharge, an unwanted discharge of milk from their breasts. Men can have these tumors, but obviously they will not have those symptoms, and they may have some decrease of their sexual drive, but that takes a lot longer to develop. The tumor has to be a lot bigger for that to happen. Other types of so-called functional tumors that cause symptoms based on their hormones are growth hormone tumors that cause a syndrome called acromegaly, and tumors that secrete ACTH, adrenal corticotrophic hormone, and those cause Cushing's disease, yes, described and named after Harvey Cushing, whom I mentioned earlier, the founder of neurosurgery. And this is what somebody with Cushing's disease looks like. Of course, I blanked out her eyes just for a little bit of disguise, but she is obese. Her face is round, her face is fat. This is not her normal appearance. She had a thin appearance, in fact, 5 years before this. She has stretch marks on her abdomen on the upper right, because this is what happens when your body has a lot of steroids in them. It could be because you're taking steroid pills, but if you've got Cushing's disease, it's because your body makes too much natural steroids. On her lower left, you could see that she has an ulcer or a wound that did not heal on her right lower leg, another effect of having too much steroids. And on the lower left image, you can see signs of bruises that occur just from trivial blows to her leg. And these are all symptoms of Cushing's disease, a condition that is really life-threatening, that requires treatment, but can result in a cure after the tumor causing it is removed. The other syndrome I mentioned a minute ago is called acromegaly, and that is caused by growth hormone-producing tumors of the pituitary gland. These are not quite as lethal as Cushing's disease tumors, but they can certainly shorten a person's lifespan, and that's by causing hypertension, diabetes, and even cardiac disease, thickening the heart muscles. And these also cause a different kind of cosmetic problem. If you look at this woman's face in the upper left, and of course I had her permission to use this photo, her features are somewhat coarsened. And if you look at her driver's license from 15 years ago, again, she looks very different now than then. Her chin is prominent, her eyebrows are somewhat more prominent than normal or the way she looked. Her fingers are definitely much bigger. She had to remove her wedding ring. She also happened to have larger feet and could no longer wear her shoes. And what the lower right shows is her MRI that shows the tumor, which is the dark area on the left in the center of the scan. And someone with an MRI that looks like that can be cured with surgery of their acromegaly. Now, there are other treatments for people with Cushing's disease, with acromegaly, with prolactinomas. They can be treated quite effectively with radiosurgery. There are certain medications that can be used to treat them. And in particular, if you have a prolactinoma, you might respond very well to treatment with a pill. And depending on how big the tumor is and what your goal of treatment is, or if you're a young woman who wants to conceive, you'd probably be better off having the tumor removed. If you're an older person who wants to prevent visual loss, then you may in fact elect to be treated with a pill only. Now, there are tumors that don't produce any hormones, and those really can't be treated effectively with any medications. And the best treatment for them is to do surgery. So these tumors cause symptoms based on their size and location. The most common symptom of which is visual loss, because as they grow up, they press on the nerves from the eyes known as the optic nerves. And this is a problem that develops slowly over time. On the left, you see the intraoperative MRI images, a head-on image of somebody with such a tumor. His symptom was visual loss, and this is what would be considered a large pituitary macroadenoma causing severe pressure on the optic nerves. The upper right image just shows a little bit of the setup in the room. The surgery is being done using an endoscope, so we're doing it looking at a screen, and the round gray circle you see there between the two surgeons is part of the view of the intraoperative MRI device itself. These are the images obtained before surgery, showing on the upper left the head-on view, the side view on the upper right, and the sort of chin-up view on the lower left. Here's how the intraoperative MRI is used during that surgery. On the left, on that column, you see a representation of the tumor before the surgery. In the second to the left column, this image was taken, I confess, after I thought the great majority, if not the whole tumor, was removed. But you look at that mass, it looks like I didn't do anything. So then I realized I had to look a little more carefully and go behind a membrane that was hiding the majority of the tumor. I took that out, and then the last two MRI images show without and then with a contrast injection that the tumor is removed. And this is 15 years later now. The patient has not had any recurrence of the tumor. So to sum up, and to talk first about the future of brain tumor treatment, there's no question that improved non-invasive diagnosis will be a reality with imaging. The idea that you need a biopsy to diagnose a brain tumor, even a glioblastoma, that is going to go by the wayside within, I would say, a couple of decades at most. In the so-called developed world, we will be able to diagnose people with pretty much any kind of brain tumor based on imaging alone. There's going to be routine use everywhere of intraoperative imaging. Practically speaking, that means MRI because it gives much more information than CT. The idea here is that you want your surgery done without the surgeon guessing. He or she should know what they're doing during surgery. And the way to know that is by doing an image. Other treatments will be personalized, and increasingly they'll be based on the genetics of the tumor. There'll be effective vaccines, immunotherapies, and targeted drugs. So that benefit that you've seen beginning with metastatic tumors, metastatic cancer to the brain, well, it'll get better for those patients, but it will be applied increasingly to patients with primary brain tumors, even the worst kind of tumors. Stereotactic radiosurgery will increasingly replace surgery for many patients. It happens now for many people with metastatic cancer tumors, certainly many people with vestibular schwannomas, and again, increasingly for people with pituitary tumors as well. And because of those considerations, brain tumor treatment, management of someone with a brain tumor is going to become increasingly an outpatient experience. Fewer people are going to have to be hospitalized to treat their brain tumor, and that's a good thing. So in conclusion, I'd like to say that, brain tumors aren't rare. Like I said earlier, odds are high, if not 100%, that you know someone who's had one. And for the most difficult tumors like glioblastoma, there is a lot of ongoing research and interest to try to make the treatments better so that the occasional person who lives a long time will actually become the norm and not something worth of special notice. And that's why anyone who's got a glioblastoma or a family member or a friend, it's really a good thing to participate in clinical trials to try to advance the state of the art. And these things would not be done if they were not safe. Another point worth making is that the majority of tumors that start in the brain, or really in the head, are benign, 2/3 of them. And many of these tumors, including some people with brain tumors, can be cured either by surgery alone or a combination of different methods. And an amazing revolution in the last decade in treating metastatic cancer to the brain. Instead of a death sentence, people can look forward to be cured much of the time. And like I said, it's not hype, it's a real thing. Our surgical techniques have gotten a lot better. You have intraoperative MRI, you have improved microscopes, you have other ways of refining the use of the operating microscope and other tools during surgery, and all that has made surgery safer and more effective. Stereotactic radiosurgery, SRS, is an effective, non-invasive, and safe option for many patients. I mean, just think, if you had a vestibular schwannoma, would you want to be in the hospital for 7 days or 2 weeks and have the risk of a stroke and other complications? Or come in and out as an outpatient and be treated in your street clothes and be done with the whole thing in half a day at most. So for me, it's really exciting to think and to work in the field of brain tumor management, brain tumor surgery, to realize how much better the treatments have gotten in the last decade, and to look forward to how much better they're going to be in the near future. So I really thank you for your time and attention. I hope this was useful and informative. You can reach me through the Northwell Health website, find the doctor function, and please feel free to do so if you have any follow-up questions. Thank you.